Hi, it's Tom here from Running Physio. Today I want to talk to you about how we can help runners that come to see us with a suspected meniscal tear. I've had quite a few questions about this recently. There's a lot of confusion over whether we can continue to run with meniscal injuries and how we rehab people in that situation. So today I'm going to talk to you about this, how we manage the acute phase, how we progress rehab, return to running and some of the key signs we'll look out for then, some simple gait changes and one cue in particular that you can use to reduce stress on the knee, and also talk a little bit about when I might feel that a surgical opinion's indicated and we might want to consider more of that surgical route. I've also put a link to our free webinars that are available now at Clinical Edge. Loads of different topics there for you: Achilles tendinopathy, lower back pain in athletes, iliotibial band syndrome. Do check those out. I think you'll find them really helpful for your assessment and treatment of runners. So let's start at the acute phase. You've got a runner that's come in with perhaps an acute meniscal injury. They've got a swollen, sore knee. They've often got some restriction in their range of movement at that stage. They might have pain and difficulty walking. They're often quite distressed. They're worried about whether they're going to be getting back into running. Perhaps they've made the mistake many of us do and they've asked Google and they've heard lots of horror stories. So how do we manage this early acute stage? Well, I think really this is all about trying to reduce pain and swelling and restore range of movement as a priority. Now, activity modification is going to be an important part of this. In this phase, we do need to stop people from running and weight-bearing activity if there's lots of pain and swelling to allow things to settle. So there needs to be a bit of activity modification. We need to try and get them to work little and often at their exercises typically at this stage. And I would focus often on restoring extension range of movement as a priority because that often gets lost. And we know the knee is often most stable in that extended position. And alongside that loss of extension range, we often start to lose some quad strength and quads bulk as well from the influence of the pain and swelling. So in those early stages, I'll be getting people doing a lot of knee extension work, little and often through the day, typically in non-weight bearing positions initially if it's better tolerated. So it might be simple things like lying on the bed, trying to gently push the knee down into the bed to straighten the knee, or seated knee extensions, little and often to try and straighten the knee. And when they're doing that, holding in those end range positions if they can tolerate it, so they're getting a bit of an isometric quads contraction whilst they're doing it. So I'll get people often doing this 3 or 4 times during the day, holding for just as long as is manageable, regularly getting this knee as straight as is comfortable and trying to bend it as far as is comfortable as well. Often in those early stages, they're going to tolerate other non-weight bearing exercises too. So we might be able to do some work on the glutes, for example, maybe some side-lying abduction work or some bridge work for the hamstrings. There's often ways that we can maintain the strength around the hip and the knee whilst they're working to restore their range of movement without doing exercises that are more likely to aggravate. Now, typically in these early stages, I don't know if you find the same, let us know in the comments, but I find it's the weight-bearing exercises that are more provocative. So I might, in this early stage, stay away from some of those activities and focus more on the non-weight-bearing stuff when restoring range and strength to allow things to settle. It's also in this early stage where there may be more of a role for our typical swelling management stuff around perhaps using a little bit of compression, elevation, maybe some ice if that's effective for their pain to try and get that swelling under control as a priority. We think that the swelling really does lead to inhibition of the quads as we've touched upon. So we want to get that under control as quickly as possible, get that extension range back. Now, we might add in a little bit hands-on stuff here too if it's tolerated. I might choose to do some gentle mobilizations into knee extension. With any of these things, I often say test is best. So we test the range, we try a hands-on treatment. If we're going to do that, we retest it and see, are we actually getting an increase in this range of movement? If we are, can we then talk the patient through how they can get similar results, how they can maintain their range using their exercises at home? So I think there can be a role for that in those early stages if we can see objective changes afterwards. So perhaps after a week or two, this acute phase is starting to settle, the swelling's starting to come down, the knee's a bit more comfortable, a little bit less irritable. This is often when I'm going to start to work into weight-bearing positions and progress the rehab. We still have some work to do sometimes to get that range back, so I'd keep them working on their little and often exercises to get their knee extension, perhaps a knee flexion back as well, and perhaps then start to introduce some balance and control exercises, single leg balance, shallow range single leg squat if it's tolerated, and then start to strengthen as much as we can around the knee. Now I like to try and have at least one closed kinetic chain exercise for the quads. So that could be squats, it could be leg press potentially, could be a lunge or lunge variation, and at least one open kinetic chain exercise for the quads. Now in that way we get to work the quads with the other muscle groups that they need to work with, but also we can try and isolate the quads to deal with any particular weakness that we might see there. So if they can tolerate it, we might get them doing seated knee extensions. If they haven't got gym access, perhaps doing that against some resistance at home. Even a good TheraBand, actually, a tougher TheraBand can work quite well isometrically. Or if they've got gym access, starting to load them up a bit in the gym to strengthen up the quads. And similarly, address any other areas that have become weak. Quads, glutes, hamstring, calf, really try and address any deficits, because the theory is if the muscles around the knee are stronger, that should add more support. There should be less stress on this meniscus during functional activity, and therefore that should facilitate their return to sport. So once we're out of that acute phase, we've restored range, we've got swelling under control. Now we're really trying to build up strength and progress the load around the knee to facilitate that return to sport. Now, as we're getting a little bit further down the line here, and timescales are a bit difficult to predict, maybe we're roughly at about 4 to 6 week stage, something like that. They're becoming a little bit less irritable. We're testing their swelling, doing things like the sweep test, and it's minimal swelling. That's when we might start to reintroduce a little bit of impact. Now this can be really simple stuff like jogging on the spot initially, or small squat jumps, progressing onto things like bounding, hopping, etc., being guided by their goals and their symptoms. But this helps to facilitate that return to running, because running obviously will have impact within it. Now, if they're then managing these things, we want to start to think about what are our key signs for return to running. What do we want someone to be able to achieve before we give them the green light to start running again? Now, the typical things I would look for is I do want that full range knee extension before we're getting back to running wherever possible. I want a quiet knee, and by that I mean a knee that's not painful with everyday activity, that can cope with walking for at least half an hour, and is not having a swelling response to those activities. We also want a knee that feels stable. So there shouldn't be any giving way with day-to-day activities. There shouldn't be any locking. And this puts us in a good position then to think about the return to running process. We might set some specific strength goals as well alongside that, but I'm often going to be more guided by some of these other factors as well. Then we would test out their impact. Can they jog on the spot for a minute without pain, without a swelling response? If they're ticking all these boxes, then we will try return to running process. Now, often this might start with something very short, because we need to look at how the knee reacts afterwards, and we can't know at the time. So I might start with a short test run of about 3 or 4 minutes maximum, and then look to see how the knee responds. Now, if we're doing that, the key signs we're going to look out for are similar to those things we're looking out for before return to running. So they're going to be, in particular, is there a swelling response? Is the knee puffing up in response to impact? Is there a pain response afterwards? Are we seeing any loss of range after returning to impact, or any sensations of instability? Because those signs and symptoms would make me think that perhaps we need to back off a little bit, continue the rehab a little bit longer before we try this return to run process. Now, a question that runners often ask, and often clinicians we want to know the answer to as well, is can you run with a meniscal tear? Is it going to harm the knee? Now, actually, some recent research from Horger et al. In 2019 was really illuminating in answering this question, as they did MRI scans of 82 asymptomatic runners that were about to train for and complete a marathon, and they found that 36% of them had a meniscal tear. So over a third of these runners with no symptoms had a meniscal tear. And we're now seeing actually that meniscal tears are quite common in runners and non-runners. They're quite commonly asymptomatic. Now in this same study, Holger et al., they then followed those runners, they trained for and completed a marathon, and they repeated the MRI scan, and they found that the training for and completing the marathon did not lead to worsening of these meniscal tears. So what it suggests to us is actually a lot of us will have a tear, can tolerate it, it doesn't seem to be made worse by running. They highlighted one particular case that they picked up in this study where someone had a bucket handle meniscal tear, what would be considered quite a significant tear. But they were asymptomatic, they trained for and completed the marathon, it didn't progress, it didn't get worse. So I do feel, yes, runners can run with a meniscal tear, and there's probably thousands of runners out there doing just that without even realizing it. But if we're going to help them with the return to run process, we want to look out for those key signs, particularly pain and swelling. Those are very key. If the knee keeps puffing up in response to running, then for me, that's a sign it's not really tolerating it very well. So good news for runners, and that's a good message when a runner comes in, if they're concerned they've got a meniscal tear, to say, actually, lots of runners are out there running on these. It doesn't seem to make them worse. We can help you get back into this sport that you love. Now, it might be that as we're coming back into the running, we want to think about some gait changes. Now, gait changes always need to be based on assessment. But one thing we do sometimes find that will increase the stress on the knee is overstriding. Now, that's often where you see a runner landing out in front of their body on a fairly straight leg. That can potentially increase the stress on the knee. So one cue that you can consider if someone is overstriding, if their step rate's quite low, is to try increasing that step rate using a metronome. Now, typically we might increase it by about 5 to 10% above what they're using at the moment. And we'd use a metronome, something like this, which you can use from various apps. And the cue's really simple. It's just run to the beat. So it's what we call an external cue. They run to the beat. What you'll find then is runners, for the most part, will shorten their stride length, which has been shown in multiple studies to reduce the stress on the knee. So that's quite a good cue to consider if someone's getting some persistent knee symptoms after a meniscal injury. But as I said, you want to base it on the assessment. This isn't something that we give to everyone. And in fact, if you've got a runner whose step rate's already very high, you know, they're 180 plus, and you put the step rate up even further, it can lead to a very shuffly, inefficient gait. So the start point there should be an assessment. Now, a lot of runners will do quite well with this approach, but sometimes you'll find that a runner just simply can't get back into their sport. And we worked with someone fairly recently who had this. Really motivated guy, worked really hard at his rehab. He got his range of movement back. He got his swelling under control. He got super strong. He was lifting very big weights in the gym, far stronger than I am. So he ticked all of his rehab goals, really ticked those boxes. But whenever we tried to reintroduce running, he just got a pain and swelling response, even with a few minutes, and it didn't seem to get better with time. So he was someone who I would say was a good candidate then to get a surgical opinion. So that would be one of our indications. And he went off, he had a surgical opinion, he'd really given rehab a good crack, it hadn't worked. They went and did an arthroscopy and removed part of the meniscus in his case, and then he was able to return to running after that process. So I think we're moving away from surgery as being the first choice, because we see actually some of the research doesn't really support that. There's also concerns about osteoarthritis long term once we go into surgery for the knee. But there are some situations where you might consider it for someone. So the main things for me would be if you have a knee that is persistently locking or giving way despite rehab. You know, they've had a really good crack at the rehab, but they're still having these symptoms of locking and giving way. Or it's persistently lacking range of movement, particularly extension, because we know that's important for the knee to function. Or if it just will not allow them to get back to their goal activities without a pain or swelling response. So if this is what we're seeing, we've tried the rehab, we've really worked at it, it's still locking or giving way, it's still painful, it's still swelling after activity, I think it's certainly worth having a surgical opinion and seeing what options might be available for that person. So we're not throwing surgery out altogether, but I think in many cases we want to try some rehab first and see how we get on, because for lots of people that will be pretty effective. Okay, so that's a quick overview of how you might manage meniscal tear in a runner. Their return to running does want to be gradual. We need to monitor their response, gradually build them up, but in many cases they can get back to decent levels without too much of a problem, providing we work through the rehab and we achieve those goals that we've talked about in terms of range and strength, control, etc. So I'd like to hear from you. What do you think with this? If you had great results with runners with meniscal injuries, or maybe the opposite, maybe you found them difficult to treat, they haven't responded well, let us know in the comments and replies, and let us know too if you have any questions. And if you want to learn loads more about running injuries, make sure you check out our free webinars. There's loads of gems in there for you, and I think you'll find them really useful. Okay, thanks again for listening. I look forward to speaking to you again soon. Bye for now.